Hello, Spencer Study Club members. Jameson here. I wanted to shoot a short introduction to this video that you're about to watch. I am so excited about this connection that has been made between Spencer Study Club and Gerety Orthodontic seminars. Now, you may not know this, but Matthew Standridge and Michael Ald, you may have seen them on the Facebook site. They are instructors for Gerety Orthodontic seminars, and they are Spencer Study Club members. And it's interesting, they didn't necessarily bring this to me, but there's other members of Spencer Study Club who were talking with Matthew and Michael and with Kay Gerety, and they said, hey, you know, we're part of this study club, and maybe we should connect in some way. And I'm super stoked about this. As you all know, these things are related, aren't they? So orthodontics and airway and all aspects of dentistry. But the cool thing with orthodontics is it gives us that ability to, one, maybe treat side effects from oral appliance therapy. If you have some spaces open, bite changes, things like that. Wouldn't it be cool if you had some skills that you could kind of do that on your own without getting your buddy across town to bail you out, so to speak? I mean, we'd rather just avoid those side effects in the first place, but the best of us are still going to have these side effects develop in some of our patients. Sure would be cool if we had those skills personally to handle those side effects. But beyond that, every time I teach a course and there are orthodontists, pedodontists, or just general dentists doing ortho in the crowd, I always compliment them on the fact that with what they're doing, with the skill set that they've developed and that they're currently developing through practice, that they can affect sleep apnea. They can possibly help their patients avoid it. Now, you all know that I don't necessarily believe that expanding the palate or something like that is going to make somebody impervious to weight gain and to other genetic factors of just a small airway in the first place. Nor is even a small airway in the first place automatically mean people have sleep apnea. Nevertheless, it seems logical to me that we would want to try to help growth and development as best as we possibly can, that we'd like to guide that as best as we possibly can. And with kids, I think the threshold for evaluation of sleep apnea and treatment of possible airway problems is super low. Because, you know, with my own kid, if I could have caught that earlier, I missed it. If I could have caught that earlier, if maybe I could have done some of these things that we know to do today, maybe that would have helped Jefferson. That would have been pretty awesome. And I think as we understand these principles more, we're going to see things that we didn't see before. We're going to have patients and their parents, mostly their parents in the case of children, reaching out to us as they talk to their friends and describe that, you know, hey, they went to this dentist and little Billy, who was wet in the bed at 6 years old, isn't doing it anymore. That is really going to build some trust in your community and help you to take your practice of dental sleep medicine and TMD to the next level. On the TMD side, very, very, very helpful to have some orthodontic skills for those patients who can't wean off their splint therapy. Now, again, you know that most of my patients were able to wean them off, but every year we have, you know, one or two or so that they can't wean off. And inevitably, I refer those patients, and I may still do that. So I'm not sure in my practice if it would make sense to do orthodontics ourselves, but in the general practices that we own in Boise, we are having our general dentists go to Gerety Orthodontic seminars to learn these skills so that we can use them and they can help us out. And I personally want to learn more about this because I think it's always better to know what your orthodontic colleagues and whatnot are doing. So again, just a little intro of how I feel excited about this. What you're going to see here is a video on some of these orthodontic principles, and it's full of pearls. As I watched this, I learned a lot. I learned, I got this much education on orthodontics in dental school, and I'm so blessed to have great orthodontists around me, and I have my whole career. But I think it's always better for us to understand these things so that we can guide our patients, we can direct them, we can help them to get to the right place and get the right care. And maybe you might be excited about learning these things yourself. And the coolest thing about Gerety Orthodontic seminars and Spencer Study Club kind of working together here is it's extremely similar. Gerety Orthodontics has online learning, and they have hands-on courses where you could start with the online learning immediately and be doing that, and then go to the hands-on courses and learn the actual wire bending and straight wire technique and stuff like that. So without further ado, here is a presentation from Matt Standridge, SSC member and faculty at Gerety Orthodontic Seminars.
Hello, and welcome to this on-demand webinar that we have created for our friends over at the Spencer Study Club. My name is Dr. Matthew Standridge, and I am a clinical instructor for Gerety Orthodontic Seminars. I am also a member of the Spencer Study Club, along with my colleague and fellow GOS instructor, Dr. Michael Auld. Going through this program and getting to know Dr. Spencer as well as our fellow students, we were very impressed with the knowledge, skill, and integrity of this group. This relationship between Dr. Spencer and GOS bloomed from feedback we received from a few mutual students who suggested that we connect. Over the last few months of correspondence, we felt that our programs complemented each other rather well. On behalf of all of us here at Gerety Orthodontic Seminars, I would like to thank you for devoting the next hour or so to our presentation on interceptive and non-extraction orthodontics and the effects that those have on proper arch, muscle, and airway development. So, without further ado, let's get started. Good morning, good afternoon, and good evening. This is Dr. Matthew Standridge, and I'd like to take a minute to introduce you to Gerety Orthodontic Seminars, an organization that offers orthodontic continuing education programs both online and in the classroom to general and pediatric dentists. We have been providing orthodontic continuing education for more than 40 years now and have had more than 12,000 doctors complete our program. Our course teaches you a predictable and repeatable protocol utilizing the straight wire technique, which will allow you to treat roughly 80% of the malocclusions that you encounter in your general and pediatric practice. I want to thank you for joining us tonight as we present a short introductory program that will familiarize you with our philosophy, concepts, and treatment objectives. The philosophy that we teach revolves around non-extraction approach, believing that it is possible to develop the arches, both upper and lower, to accommodate the correct position of all the permanent teeth. More importantly, we emphasize the concept of treating the cause of the constriction, crowding, or malocclusion, rather than just treating the result. This concept has led us to early treatment and a more thorough and complete initial examination. All of our instructors were very fortunate enough to train under and following the teachings of Dr. Ray Greenfield, by far the most respected and accomplished non-extraction orthodontist in the world. Through his teachings, we have learned more and more about the causes of malocclusion and the changes that are necessary to treat to an unquestionable degree of stability. In this slide here, Dr. Greenfield developed the coordinated arch development criteria as part of his non-extraction philosophy. And I fully recommend you check out his textbook, Non-X Factors, 98.5% non-extraction, where he goes into his philosophy in much more detail than what we will here tonight. So, focusing not only on teeth, but more so the environment that the teeth exist. Our philosophy also teaches you the importance of nasal breathing, adequate airway, and proper function of the entire stomatognathing system. In order to successfully treat malocclusions, the clinician must treat the cause, not the symptoms. For example, when the tongue assumes its correct posture, the development of the dentition proceeds in a natural progression as illustrated in images A through C. A sagittal section, which is image D, depicts the normal relationship of the lips, teeth, tongue, and related structures in the act of swallowing. However, if the tongue is displaced due to environmental factors such as thumb sucking, mouth breathing, etc., the teeth may erupt and or drift to the lingual, the area of the least resistance, and in some instances can over-erupt as illustrated in images A through C. As a result of this lack of proper function, the transverse and or vertical dimensions may be compromised, leading to a constricted arch form. The sagittal section in image D illustrates an abnormal relationship of the lips, teeth, tongue, and related structures in a mouth breather possessing a malocclusion. Subsequently, the dentition is displaced mesially, leading to crowded and or protrusive dentitions as illustrated in these four images. It is up to the clinician to reverse these events and restore the arch form back to its original state. Another element of our non-extraction philosophy is placing the teeth in the neutral zone, or the area between the lingual and buccal musculature as illustrated in images A through C. Extractions and or protracting molars into areas normally occupied by bicuspids may test the neutral zone, causing the buccal musculature to displace the posterior teeth lingually, as shown in image D. Lingually displaced molars may in turn be displaced mesially, resulting in incisor crowding long term. Quite often during treatment, through improper use of mechanics, anterior teeth are moved too far forward, or quote-unquote dumped forward, resulting in the anterior teeth being outside of the neutral zone. The use of the lip bumper is instrumental in developing the arches to accommodate the position of the full dentition in the neutral zone. Violated neutral zone results in lingually displaced posterior segments, mesially displaced posterior and anterior segments, compromised function, compromised periodontium, and compromised dental and facial aesthetics. Any combination of these five factors results in compromised long-term stability. Therefore, control of the neutral zone is imperative. The control and final position of the maxillary anterior teeth, not the mandibular anteriors, arguably are the most important factors in achieving a successful orthodontic result. Without properly intruding and torquing the maxillary incisors to provide maximum intercuspation and light anterior centric stops, see image A, incisal guidance will be compromised, the overbite will deepen, and the posterior teeth will drift mesially long term, as shown in image B. Incisal guidance, posterior occlusal guidance, and condylar guidance are interrelated and interdependent. If intrusion and retraction are not done simultaneously, the incisors will extrude during retraction, creating a biplanar occlusion, a situation not conducive to long-term functional stability. Protrusive incisors may also initiate a premature incisal contact, see image A, thereby compromising incisal and posterior guidance, image B, and displacing the condyle, image C. Thus, a chain reaction of damaging events may occur from lower incisor protrusions resulting from constricted arch forms. Attention to these components is necessary to achieve long-term stability. Therefore, proper torque and intrusion of the anterior teeth are a critical component of a healthy stomatognathing system. One must first understand that changes in the transverse dimension significantly affect the sagittal and vertical dimensions. If we take a sphere, i.e. a closed system, and compress the transverse dimensions, the vertical dimension or height will increase. The sagittal dimension or depth will also increase, as shown in the illustrations. The same holds true for the human dentition. When both arches constrict, a tooth size arch size discrepancy may develop, as seen in image A, and the anterior segment becomes more procumbent. Once the arches are developed, leveled, aligned, and rotated, note the amount of transverse dimension that was gained, but also the change is in the sagittal dimension. A constricted arch produces procumbent incisors, like we talked about. And then the transverse dimension results in a decrease in the sagittal, as shown here. So now that we've kind of primed a little bit about our philosophy and objectives, let's talk about our patient documentation and exam. Our records documentation consists of 5 segments and a thorough examination of each of those segments. For the purpose of this short presentation, I want to review our examination of the health history as well as the oral examination, where we screen for TMD, airway issues, orofacial myofunctional concerns, and any history of trauma. We examine and evaluate the patient from not only a dental and orthodontic perspective, but also a myofunctional perspective as well. Examining the TMJ as part of the initial oral examination is imperative. Studies indicate that TMJ disease is neither improved nor worsened as a result of orthodontic treatment. Thus, a record of TMJ symptoms before treatment is needed for all concerned. Some TMJ disorders are detected at the pre-treatment examination may benefit from orthodontic treatment, whereas other disorders may either complicate treatment or be a contraindication for orthodontic treatment. In the past, with our general students, we've always advised referral to a specialist in the diagnosis of the treatment of TMJ disorders is a wise decision when symptoms, radiographic evidence, and history suggest the presence of a complicated disorder. However, we know that this group is not the average and may be more capable of handling such complications. Either way, informed consent before orthodontic treatment should be obtained from patients who have positive findings. A simple screening tool procedure for clinical evaluation of the TMJ is done using the TMJ tri-measure to measure the vertical opening as well as left and right deviations. As shown in this picture here, to measure the vertical opening, simply insert the tri-measure into the patient's mouth during maximum extension opening and measure the opening by positioning the incisal edges on the teeth on the scale. Here we are using the tri-measure to measure left and right deviations. We measure how far the midlines have traveled in excursion. To measure the left and right deviations, position the tri-measure so that the straight edge is lined up with the upper incisal edges. Place the 0 exactly on the dental midline of the upper arch. Instruct the patient to shift their mandible to the right or the left as far as comfortable. Measure the lower dental midline. It should be noted that if there is a midline discrepancy, that needs to be taken into account when measuring the deviations. For example, if the patient's lower midline is off 1 millimeter to the right, when you measure the right deviations and it's reading 10 millimeter mark, the actual movement was only 9 millimeters. And to the contrary, to the left, if the reading was at the 10 millimeter mark, the movement was actually 11 millimeters. Another area of examination that we feel is very important and oftentimes overlooked is the orofacial myofunctional examination. Examples of things to look for include inadequate lip seal, labial and lingual frenum attachments, mouth breathing, quote-unquote allergic eyes or frontal nasal irregularities, normal head and neck posture, airway evaluation to determine if compromised, abnormal tongue position or tongue thrust, grimacing during swallowing, and grinding and or bruxing. So let's talk about inadequate lip seal. So does the patient have flaccid lips, tight labial frenums, an overdeveloped mentalis? Is there anything physically preventing a lip seal? More than 90% of the time, inadequate lip seal is caused by mouth breathing. And as we learn more about growth and development, as well as the blooming science on airway, is becoming more apparent on how important nasal breathing is both to our growth and development, but also our general health. Here we show a patient with allergic eyes. It's that sunken in, bags under the eyes look. We also look at the nose. If you see a bulbous nose with very small, almost pinpoint-like nares, they are likely to be breathing through their mouth. When we breathe through our nose, we use musculature that leads to muscle tone. If the nose is rounded and without muscle tone, it's more than likely not being used much. We also want to look at head and neck posture. If they have a forward head posture, that may be a compensatory position to increase airway. We also keep an eye out for abnormal swallowing or tongue thrust. If at any point you are concerned about airway issues, we encourage you to seek consult with an ENT that is up on the airway science. In our comprehensive program, we teach both Phase 1, also known as interceptive early treatment, as well as comprehensive treatment. We have a strict protocol and diagnostic criteria for our beginning students, those who are completely new to orthodontics. We offer indications and case selection criteria for both Phase 1 and comprehensive treatment. So let's begin with interceptive Phase 1 treatment. Treatment intervention in the mixed dentition is recommended when there has been premature loss of deciduous teeth resulting in loss of arch length, arch constriction in either arch, whether there is moderate to severe crowding of the permanent incisors, if there's an excessive overjet, when either a posterior or anterior crossbite is present, or any time that we diagnose any orofacial or myofunctional concerns. Our objective for Phase 1 treatment is to get in, fix the problem, and get out. We estimate a treatment time of between 6 to 12 months depending on the severity of the problem. These models demonstrate a typical scenario for interceptive treatment. Treating with several different mechanics, our objective is to fix the problem and restore the dentition, allowing a normal exfoliation and eruption pattern to occur. If the permanent teeth are crowded and blocked out, or if the individual has lost space, we need to create space for the crowding, and the lost space needs to be regained. We need to address anything that is wrong that could be more easily treated at this particular time rather than waiting for full comprehensive treatment when they're 11 or 12 years old. This patient here presents with two of the indications for phase 1 treatment with a premature loss of deciduous teeth resulting in loss of arch length and crowding of the permanent incisors. Now, there is not an ideal age for interceptive treatment because it varies. It depends on the patient's age dentally and what the concerns are. Phase 1 or interceptive orthodontic treatment should always be considered when there is moderate crowding, any loss of space due to extractions or premature exfoliations, or severely rotated or malaligned teeth that are erupted. Let's take a look at two cases, brother and sister. The brother is age 10, but dentally he is much younger than his 8-year-old sister. His arches are constricted with severe crowding, upper and lower. Both upper permanent laterals and lower right permanent lateral are blocked out. The sister, age 8, is much more developed dentally and has constricted arches and moderate crowding. Both of these patients are positive indications for interceptive treatment. Literature published by Bjorn Zackerson, DDS and MSD PhD, emphasizes the importance of treating crowded or rotated teeth at an early age to improve stability. He states, quote, "Resolving the issues of crowding and arch constriction in the mixed dentition lessens the severity of the comprehensive orthodontic treatment during the permanent dentition." End quote. In other words, if we intervene and recreate the space, develop the arches, address any rotations or crowding, and get the teeth in a position of normal eruption of the permanent teeth, that will make our comprehensive treatment much less complicated. Also, by placing these teeth in the proper position, the easier they are to move and the less their tendency to rebound because they have not been in a malaligned position for 4, 5, or 6 years just waiting on treatment. By addressing these concerns with fixed appliances, we not only develop the arches and make room for the permanent teeth, it allows you to individually correct the position of the teeth for aesthetics. When we use removable appliances, it's not always possible to tip, align, and rotate the teeth to the aesthetic level that both you and the parent are hoping for. We could use a transpalatal quad helix Schwartz or crossbite appliance and get improved arch development and even create space. But we still don't have the individual tooth position that makes those transitional years so much better for the patient. Individually addressing the position of the molars, closing spaces, and rounding out the arches is a much better treatment option for the patient than just doing some arch development and not addressing the teeth selectively. Anterior, posterior, or class 2 corrections are not recommended in the mixed dentition, and this is our reasoning for that. So if a patient is class 2, we do not attempt to correct the class 2 dental relationship in the mixed dentition because of the length of treatment. The patient would have to be in some type of active treatment until permanent teeth erupt because the flat planed occlusal surfaces of the primary teeth will not maintain that AP correction. You can mechanically make the class 2 correction in the mixed dentition, but because of the flat planed occlusion surfaces of the primary teeth, they don't really interdigitate, and so it will allow the occlusion to slide. You need the interdigitation into the embrasures like what you get with the premolars in the permanent dentition, and that would lock in the occlusion. What we try to do is initiate treatment to correct any discrepancies, any arch length issues, any space loss, crowding, or rotations. Fix the immediate problem and prepare the arches for a normal eruption pattern of the permanent teeth. Dr. Panchers has well documented that. He states that, quote, maintaining an anterior-posterior correction in the mixed dentition is difficult, if not impossible, due to the flat-planed occlusion of the primary teeth. In order to maintain the correction, appliances will need to be worn as a retainer until the permanent teeth erupt, allowing the dental intercuspation to retain the correction. End quote. Flared anteriors of Class II Division I cases can be improved dramatically by tipping the maxillary teeth lingually for aesthetics and prevention of trauma while we're waiting for the Class II correction to be made during the permanent dentition. This conservative approach will allow us to resolve the primary concerns within a reasonable amount of time of 9 to 12 months. Dr. Panchers further states, quote, while correction of the dental and skeletal Class II malocclusions can be completed in the mixed dentition, the treatment time can be excessive due to the retention phase necessary to maintain the correction. End quote. Almost all cases that are started in the mixed dentition can be treated non-extraction, and there are a lot of reasons for this. We have so much space available to us in the mixed dentition that we can take advantage of. For instance, we gain 3 to 4 millimeters per side if we don't allow the permanent first molars to move forward at all. This is what we refer to as preserving the E-space, which is the difference between the mesial-distal width of the deciduous second molar and the mesial-distal width of its replacement, the second permanent premolar. While the deciduous cuspids, first and second primary molars are being lost and waiting for their replacement teeth, freeze the lower permanent molars and you can pick up 3 to 4 millimeters per side. Another treatment mechanic that we try to be aware of and utilize in the mixed dentition is the fixed 3D lower lingual arch, or the removable lip bumper. So first, let's discuss when we would use a lip bumper and when we would use a lower lingual 3D for the space maintenance and space correction. There are advantages and indications for each. If a person has a lip habit and have lower incisors that are lingually inclined due to lip sucking habit, or if the patient has a constraint placed on the teeth by the orbicularis oris or the mentalis muscles, a lip bumper will help retrain those muscles, change the environment, and allow the tongue to develop the arches. So it is a great myofunctional appliance. As you can see in this example, there is a tremendous amount of transverse development on the lower arch as a result of the lip bumper. This Boley gauge measured the progress model after 9 months of lip bumper treatment, and you can see the amount of lateral development from the original model. Now, I will caveat this by saying the one negative with the lip bumper is patient compliance. Because it is removable, the patient has to cooperate with the wearing schedule. If you're dealing with a patient that you know has a history of noncompliance, I would lean towards going straight towards the lower lingual 3D. So speaking of that, if the patient is not a lip sucker and you don't need to address the musculature problem, the 3D lower lingual appliance is a more hassle-free appliance, but it does nothing to change the environment. The 3D lower lingual will freeze the molars just like the lip bumper, and also has adjustment features. You can adjust the 3D for uprighting the molars, advancing the anteriors, expansion or molar development by tipping the crowns. You can also rotate or torque with the 3D lower lingual appliance because of the vertical slots that seat into the lingual tubes of the molar bands. Either one of these appliances is effective in the mixed dentition for space maintenance as well as arch development. The fixed 3D lower lingual is our preference for a retainer on the lower following interceptive treatment. In more constricted cases in the mixed dentition, we need to take advantage of a fixed technique that we've been using for at least 30 years that has been very successful. This technique is bracketing the primary dentition along with any permanent teeth that are erupted. In constricted cases, we get great lateral development and space regaining through bracketing the primary cuspids and the primary first and second molars and progressing through an arch wire sequence. We have said repeatedly in our classes, teeth don't recognize the difference between being pulled into place with an arch wire sequence or pushed into place with a piece of acrylic from the lingual. What we like to do, especially if we're struggling with crowding and rotations, is to place cuspid, first, and second premolar brackets on the primary cuspids, first and second deciduous molars. Now you can use your standard brackets and place the permanent cuspid brackets on the primary cuspids. You place the first permanent premolar brackets on the first deciduous molars and place the second permanent premolar brackets on the second deciduous molar. Of course, the permanent central and lateral brackets are placed on the permanent central and laterals. And we place molar bands on the permanent first molar bands. The placement of these brackets on the primary teeth is not necessarily critical. You are not concerned with the tip or torque or full expression of the movements that are built into the straight wire bracket. We simply need to engage them into an arch wire and develop the arches. When placing brackets on our primary teeth, we place the brackets as gingival as possible, and we try to find a stable position on the tooth that the bracket seats most steadily without rocking, and actually place the bracket as gingival as possible so that is nearer to the center of rotation. We progress through the routine arch wire sequence of twisted 0175 stainless steel, then 016 and 018 round wires. Once we're up to the 018 arch wire, we introduce open coil spring where needed to gain sufficient space or regain lost space. Once you've gained adequate space, we bracket the blocked out teeth and engage a flexible wire such as the twisted 0175, or you can use an 016 thermal nickel titanium and progress back through the arch wire sequence of 016, 018, and ultimately 020. Now it should be noted that the routine arch wire sequence we're using are made up of stainless steel arch wires. And that is because we have found much more lateral development of the arches from stainless steel wires over nickel titanium. So once the arches are developed and the crowding has been eliminated, place an upper Hawley retainer and a fixed lower lingual for retention. On the lower, place a fixed bonded lower lingual on the 4 permanent incisors if there are no missing teeth. If there are missing teeth or the arch space is to be maintained, place a fixed lower lingual arch from permanent first molar to first molar, retaining the arch length and any spaces. The upper retainer is worn for 6 months full time and then can be discontinued. The lower lingual arch should be worn until the exfoliation of primary teeth. So let's look at a couple of before and after cases using this fixed technique. These are the pre-treatment models of a young female patient, age 7 years, 5 months, and presents in the early mixed dentition. The parent's initial complaint was the spacing and blocked out teeth on the upper arch. One of the criteria in our comprehensive protocol is that we suggest not doing one arch treatment as part of comprehensive ortho, but single arch treatment in the mixed dentition is quite often indicated. The patient is class 1 dental with the proper overbite with crowding of the maxillary incisors. The occlusal view of the models show a lower arch with no crowding and only some minor rotations in the lateral and the presence of all of the primary teeth with normal exfoliation pattern. The upper arch is slightly constricted with mild crowding in the anteriors only. The treatment plan for this patient was a single arch treatment of the maxillary arch by placing brackets on all teeth, deciduous and permanent, and progressing through the arch wire sequence to develop the anterior segment and eliminate crowding. The space between the centrals was closed using chain elastic and along with the development of the arch with the arch wire sequence. Sufficient space was gained for the eruption of the permanent laterals. The occlusal view shows an improved arch form and alignment of the upper anterior teeth. The treatment time for phase 1 treatment can be somewhat difficult to accurately predict due to timing the complete eruption of the permanent incisors. A series of facial photographs for the patient shows a normal developing facial symmetry and a balance with no orofacial concerns. During phase 1 treatment, our sequence of arch wire is through an 020 stainless steel round wire. We do not progress to the rectangular wires. These photographs were taken at 1 year of active treatment and no open coil spring was necessary on this case. The upper arch has developed good arch form with the arch wire sequence and the anterior teeth have acceptable alignment. The lower arch was never really a concern. After 1 year of treatment and removal of the appliances, the patient has a great profile as well as a nice, big, broad, full smile. This is the comparison of pre-treatment models and retention photographs. Crowding has been eliminated and the upper arch is leveled and aligned. The dental midline is addressed and adjusted, and the dentition prepared for the eruption of the permanent teeth. The patient is class 1 dental and skeletal and normal overjet and overbite. Here we see the permanent premolars are erupting into the arch. The occlusal view of the upper arch shows an improved arch form and nice development. The lower arch was untreated and has adequate space to accommodate the permanent dentition. Now these are 1 year post-treatment intraoral photographs. She has maintained an acceptable anterior relationship and is in the final stages of the eruption of the permanent teeth. The upper and lower arch form is adequate and sufficient space for all permanent teeth. These photographs were taken 2 years post-treatment and all primary teeth have been exfoliated. All permanent teeth are present in the arch form but not completely erupted. Here, both upper cuspids and all 4 second molars are currently erupting. And here we show facial images showing a beautiful young lady. Now these photographs are 3 year post phase 1 treatment and the patient is almost 13 years old now with all permanent teeth fully erupted. This is a patient of record in practice that we were able to closely monitor. Both patient and parents elected not to pursue comprehensive treatment, which would have entailed final bite opening and improvement of the angulation of the anterior teeth for a better interincisal angle. But that's kind of getting nitpicky. The lateral mirror views of the posterior occlusion show a class 1 dental relationship. The permanent teeth are completely erupted into the arch and have nice alignment and nice arch form. Now, these photographs are 9 years post phase 1 treatment, and the dentition is stable in alignment and arch form. The bite is somewhat deeper than we would like, but is very acceptable since the patient elected to forego comprehensive treatment. The lateral mirror views of the posterior occlusion show a class 1 dental relationship that is maintaining. Both upper and lower arches have maintained the integrity of the arch form with no relapse of crowding in the anterior. And I have to say that is one of the beautiful things, that when you maintain neutral zone, you are much less prone to relapse, as we found out. So let's look at one more interceptive case with both arches treated. This is a 10-year-old male who presents in the mixed dentition. This young man has moderate crowding in permanent incisors, upper and lower. The upper and lower occlusal views show constricted arches and the presence of all primary teeth. The pre-treatment models show a 100% deep bite, normal overjet, and a class 2 dental relationship. Occlusal views of the model show the constriction of the arches and detail the crowding of the upper and lower incisors. Note there is a retained primary lateral on the lower arch that will be removed. The pre-treatment Panorex is unremarkable, showing the presence of all permanent teeth and dental development that is behind in accordance to the chronological age of the patient. The latent dental development will facilitate the completion of phase 1 treatment on this patient, even though he is age 10 and a half when treatment is initiated. The pre-treatment Ceph is normal with a class 1 skeletal relationship, a neutral growth pattern, and normal incisor ratio. The treatment plan for this patient was to bracket all available permanent and primary teeth and begin a routine arch wire sequence to develop the arches laterally and anteriorly to alleviate the crowding in the permanent incisors. These photographs are 3 months into treatment and are up to a 016 stainless steel round arch wire. We have consolidated the space between the centrals, which allowed the upper left lateral to erupt, and we are waiting on the upper right lateral to erupt into the arch further to accommodate a more accurate placement of the bracket. The arches are shaping and developing to the arch wire sequence. We avoid placing a bracket on any blocked out teeth until we have gained sufficient space in the arch. Once we get to the 018 stainless steel round arch wire, we can incorporate open coil spring to gain space for the blocked out laterals on the lower. You will notice that the diastema has reopened due to the maxillary midline frenum that extends to the lingual and also incorrect bracket placement of the upper right central. The root of the central incisor is tipped to the mesial. An excessive frenum attachment can be diagnosed by lifting the upper lip and checking for tissue blanching, labial to lingual. If blanching occurs, the patient is referred to the periodontist to remove the fibrous tissue and muscle attachment completely. We have found the periodontist does an excellent job of tissue management. We do not refer patients in the transitional dentition for surgery unless the diastema is severe and causing ectopic eruption of the permanent laterals. We postpone surgery until the permanent cuspids have erupted, which is normally in comprehensive treatment. Now, that being said, if you do have, you're skilled with frenectomies, you have a laser or anything like that, This is something that can be done in your office if you so choose. 7 months into treatment, and we have gained sufficient space in both arches to accommodate placement of the blocked out teeth. The upper right lateral has erupted to allow bracket placement and incorporation into the arch wire sequence. We're unable to get full bracket engagement on the lower laterals, so we dropped to an 018 nickel titanium arch wire and placed extended steel ligatures on the teeth to gently move or tease those laterals into the arch form. So here we have progressed to the 020 stainless steel arch wire on the upper and have maintained the 018 NiTi arch wire on the lower. With the lower laterals moved labial, we can now get full bracket engagement in the flexible arch wires for final alignment of the blocked out laterals. We have improved arch form of both upper and lower arches. The titanium wires are excellent for moving teeth into final position. You can use a larger gauge wire, and the NiTi provides the flexibility required to move the tooth into alignment. Here we show a chain elastic is placed on the 4 incisors to consolidate spacing. The 0175 twisted arch wire is placed on the lower arch after some bracket repositioning to correct minor rotations in the lower incisors. For phase 1 treatment, we progress through to the 020 stainless steel arch wire upper and lower. As you can see in this photograph, the midline diastema is back, largely due to bracket placement along with the frenum. The bracket is placed incorrectly with the root of the tooth tip to the mesial rather than to the distal like we would want. Here we show the occlusal views, show well-developed arches, both upper and lower, with adequate alignment of the permanent incisors. Chain elastic on the upper arch, molar to molar, has consolidated all spaces with no excess tissue bundling. Now let's look at the comparison views of the pre-treatment models and post-treatment photographs. Our objective for interceptive treatment was to align the permanent incisors upper and lower and develop the arches for a normal eruption sequence. There is sufficient space for the permanent teeth in both arches. After 1 year of active treatment, the permanent teeth are leveled, aligned, and rotated, and we have maintained all of the primary teeth. The patient has a slight class 2 dental relationship that can be addressed in the comprehensive treatment plan. There has been significant change in the maxillary arch form through utilization of the primary teeth and arch wire sequence. A frenectomy was performed prior to starting comprehensive treatment. The lower arch has developed laterally and anteriorly to accommodate the position of the permanent incisors. Particularly note the development in the cuspid and premolar area. A bonded lingual retainer is placed lateral to lateral on the lower. This big, beautiful arch forms. Plenty of space for the tongue. These photographs were taken 2 years after phase 1 treatment was completed and prior to comprehensive treatment. The incisors upper and lower have maintained their alignment. The bite has deepened and the posterior occlusion is end-to-end or just a mild class 2. With no crowding present, upper or lower, comprehensive treatment is simply a matter of bracket placement, arch wire sequence, leveling, aligning, and rotating. Once the lower arch is in an 018 by 025 stainless steel, the MDA, which is short for the multi-distalizing arch, will be used on the upper arch to establish the posterior occlusion to class 1. These photographs were taken 16 months after beginning comprehensive treatment. The patient is in upper and lower 018 by 025 arch wires with Pletcher springs on the upper for final bite opening and space closure. The posterior occlusion is a nice class 1 relationship. Midline is correct and all spaces are closed. We have acceptable arch forms, second molar to second molar, upper and lower with nice alignment, arches leveled, and no spacing issues or diastemas. After 11 months of interceptive treatment and 16 months of comprehensive treatment, these are the finished results. The midline diastema that we struggled with during phase 1 treatment is no longer an issue. The bite is leveled and opened with acceptable class 1 interdigitation and dental midlines. This case worked exactly as planned for phase 1 and comprehensive treatment. That is not always the case, and timing of the treatment is critical for both phases. The occlusal views show good arch form, alignment, and symmetry, and a bonded lower lingual retainer is placed cuspid to cuspid. 2 years post-treatment, document the stability of the treatment with the maintenance of bite opening and class 1 dental relationship. Both arches are well developed and free from any rotational relapse. The patient's lower lingual was removed by his family dentist and he chose not to have it replaced, and was informed that a relapse was likely to occur in the lower incisor area. Now let's discuss comprehensive orthodontic treatment. The most important aspect of orthodontics for the beginning student to understand is the significance of case selection. Orthodontics for the general and pediatric dentist should be enjoyable and rewarding. As a non-orthodontic specialist, we have the option to be selective in the cases we treat, so we encourage you to select cases within the parameters that we suggest. We offer all of our comprehensive students an additional year of classroom training for no additional fee because we feel very strongly about supporting our doctors and providing continued guidance. This 2-year period of time will allow you to start and finish cases with continued monitoring, allowing you to gain confidence and experience success. Now, let's look at some cases that would fit the case selection protocol for the beginning doctor. We'll look at before and after cases, and I'll give you just a brief explanation of each without getting technical about the procedures or mechanics that were used. So this is a patient, female, Caucasian, age 11. She has a normal to mild convex profile with the lower lip slightly protrusive. Dentally, she presents in the late mixed dentition with moderate crowding upper and lower. She is class 2 malocclusion, deep bite dental. The occlusal images display constrictions of arches, moderate crowding, and the presence of the lower second deciduous molars and lower permanent cuspids that have drifted and erupted mesially on the lower arch, likely due to the premature loss of primary cuspids. Her models give a less distracted illustration of the severity of the crowding. The occlusal views of the model details the constrictions and anterior positions of the lower cuspids. These images were taken 16 months into active treatment. Our sequence of mechanics was banding the upper and lower first molars, placing direct bond brackets on all available teeth on the upper arch, progressing through a routine arch wire sequence on the upper. 6 weeks after initial placements, we seated the lower lip bumper. Without getting into a lot of specifics of the mechanics, as you distalize and develop the lower arch with the lip bumper, it will become necessary to distalize and develop the upper arch. So 3 months after delivering the lower lip bumper, we seated an upper transpalatal appliance and continued to adjust the lip bumper and transpalatal along with the upper arch wire sequence. Once the lower arch was established to the anchorage arch wire, the MDA appliance was used to distalize the posterior segments into a class 1 relationship. The intraoral occlusal photographs are extremely noteworthy. On the upper, the archwire sequence along with the transpalatal appliance has developed the arch and eliminated the constriction. The upper molars have been distalized and distally rotated, and the anterior teeth have been aesthetically aligned. The basic function of the lip bumper is to respond to the buccinator muscles applying force through the function to the lower arch. Not only does the lip bumper tip, rotate, and upright the lower molars, it acts as a functional matrix to keep the lips and cheeks away from the lower teeth, allowing the tongue to function and develop the lower arch. In 16 months, through the utilization of E-space and passive arch development, the crowding of the lower arch has been resolved without unnecessary flaring of the lower incisors. You can see the space that has been created on the upper arch, and we never really worry about mechanically closing these spaces. There will be some rebound, and that is not a concern. Should the spaces not close up, these are things that we can always address in finishing. These are occlusal view stage models of the lower arch pre-treatment, post-treatment, post-lip bumper, and post-archwire sequence to illustrate the arch development on the lower. The anterior and sagittal views of the lower arch post-archwire sequence illustrate arch leveling. These are right and left sagittal views of the pre-treatment models, post-lip bumper models, and post-MDA models. You can see, if you take a look at the molars and the premolars, how they've been distalized, how those premolars are going nicely into those embrasure forms. That is what's going to set us up for a very, very solid, stable occlusion over time. These photographs were taken 24 months into treatment during the final space closure and fine-tuning. Chain elastic is used to consolidate the space of the upper anterior teeth and maintain the midline correction. Chain elastic is used on the lower arch to shift the lower midline to the right, taking advantage of some slight space for finalization. These are some comparison photos to the beginning models with the post-treatment intraoral photographs. The frontal view shows correction of the deep bite with the arches leveled, aligned, and rotated, and good vertical dimension established and proper overjet and overbite. The right lateral view shows the correction of the Class 2 dental malocclusion to a solid Class 1 relationship with the posterior teeth locked into the embrasures. The left lateral view shows the correction of the Class 2 to a solid Class 1, again with the posterior teeth locked into the embrasures. Note the development of the upper arch in the approved arch form using the transpalatal arch early in treatment and combining the routine archwire sequence to continue the development. The lower arch was developed primarily through the use of lip bumper to resolve the constriction and crowding. The archwire sequence continued to level, align, and rotate the lower arch. The extraoral photographs show a beautiful young lady with a gorgeous smile and profile. These are retention images taken 5 years post-treatment, and everything is maintaining very nicely. The bite opening is holding up, no collapse of the vertical dimension, and the posterior interdigitation is still good. Upper and lower occlusal images show the lower lingual retainer has been maintained, and the arch forms show no sign of relapse or constriction. These are retention images taken 10 years post-treatment for documentation of the stability of the treatment mechanics used. Both upper and lower arches look fine because the lower second molars were not completely erupted before completing active treatment. Their position is not ideal but acceptable. For time purposes, I'd just like to show you some more cases with just before and after only, so you can see the cases that could be treated and results that you could expect for patients. So this young lady is 15 years old. She has an impacted upper left cuspid and has retained the upper left primary cuspid, and presents with good overjet and overbite. The occlusal views show the eruption of all other permanent teeth with mild constrictions and crowding. She has a bilateral asymmetric two-size discrepancy in the upper lateral incisors. The pre-treatment study casts show an end-on-end class 2 posterior relationship on the right and a class 1 relationship on the left, thus defining the slight midline discrepancy to the left there. Occlusal views of the models better illustrate the two-size discrepancy on the upper laterals and the mild crowding on the lower laterals. And these are the finished results with less than 2 years of total treatment time. The bite is opened, arches are leveled, the overjet and overbite are ideal, and we have the correct amount of spacing on the upper lateral incisors for cosmetic bonding, mesial and distal, with the dental midline corrected. The upper and lower arch form is well developed, and the lower lingual bonded retainer was placed on the 6 anterior teeth, bonding individually to each tooth. She has a beautiful smile, broad arches, and full facial complex. Our next patient is a 13-year-old female with a palatal impacted upper left canine. She has retained the upper left primary cuspid and has a slight midline deviation to the left as a result of that. She presents with normal overjet and normal overbite. Both upper and lower arches are constricted with mild crowding of the lower arch in the anterior region. The upper left second premolar is slightly smaller than normal and somewhat malformed. The pre-treatment study casts show a mild class 2 occlusion. The distal margin ridge of the upper first molars does not contact the mesial marginal ridge of the lower second molar. The position of both lower canines is far too mesial, which adds to the false appearance of a class 1 relationship. Through bracket placement and arch wire sequence, the upper and lower arch will be developed laterally to eliminate the crowding on the lower arch. Without patience and diligence to lower arch transverse development, this case could turn into a mandibular distalization case due to the position of the lower cuspids. That's something to kind of keep an eye out for as a side note. Keep an eye out for those lower canines. If they're far too mesial, that might be a wolf in sheep's clothing, if you will, that there's more crowding than what you may think. These are the finished results after 26 months of treatment that were taken the day that the bands and brackets were removed. We established a class 1 dental relationship with acceptable overjet and overbite. The dental midline has been corrected and the impacted cuspid has been properly aligned. And here are our laterals showing nice class 1 and nice interdigitation into those embrasures. The upper arch is maintained with a removable Hawley and a bonded retainer, cuspid to cuspid, bonded each tooth on the lower. Here are images 2 years post-treatment, and everything's holding up very nicely. Posterior occlusion is stable, and the development integrity of the arches, both sagittal and transverse, is maintaining. That's the beautiful thing about getting stuff within that neutral zone. Alright, gang, so I want to say once again how much I appreciate the opportunity to present this information to you. Our hope is now that you see what's possible through early intervention and comprehensive treatment, and the implications that this can have on your pediatric and adolescent patients. Where there is certainly a place for managing airway and sleep apnea, we would also like to help reduce the chance of such conditions if at all possible. As a token of thanks, I would like to extend a special offer for Spencer Study Club members. Mention this program and we will gift you $500 off either our online or in-class comprehensive program. As of the date of this recording, that brings the cost of the on-site program to $4,995 or the online program for $4,300. For more information, you can check out our website at www.orthodonticteaching.com. You can email Julie at customer-service@orthodonticteaching.com or give us a call at 918-606-2809. Again, I so very much thank Dr. Spencer for inviting us to present to you guys today and really talk about early interceptive treatment and getting these kiddos and adolescents so we can help maximize their full genetic potential. Again, thank you so much and have a wonderful day.